want you to take a second and just think about two things that you probably take for granted every single day. First is speaking, and the second is breathing.
Right, just the basics.
Yeah, exactly. But imagine waking up tomorrow morning, opening your mouth to say hello, and your voice has just completely vanished. Or imagine simply climbing a flight of stairs, like a flight you walk up every single day, and suddenly feeling this inexplicable, terrifying inability to catch your breath.
It's a profound loss of control. We were talking about two of the most fundamental automatic functions of the human body here. When they fail, that distress is immediate.
Oh, absolutely.
Because you are suddenly disconnected from your ability to communicate with the world, or, worse, your ability to physically remain in it.
And that right there is what we're focusing on for today's deep dive. We are unpacking the clinical decision-making algorithms for two incredibly common, but honestly shockingly complex medical symptoms.
Yeah, they really are.
The first is hoarseness, which the medical world calls dysphonia, and the second is shortness of breath, clinically known as dyspnea.
Right, and to really understand how doctors tackle these issues, we are drawing directly from clinical textbook chapters from decision-making in otolaryngology.
Which is quite the read.
It is.
Okay.
But these sources, they map out the exact diagnostic flowcharts, the decision trees that medical professionals actually use to solve these physiological mysteries. So we are looking at how a physician navigates from a patient's incredibly vague complaint to a very specific and sometimes life-saving intervention.
Okay, let's unpack this, because taking these dense, intricate medical flowcharts and translating them into a journey through the human airways would be a really fascinating ride. Let's start with losing your voice, dysphonia.
Yeah, dysphonia.
Most of us just think of it as sounding a bit scratchy after a loud concert, or catching a cold.
Well, clinically, dysphonia is a much broader category than just a scratchy throat. It actually represents any abnormal voice quality. So it includes a loss of volume, like an inability to project across a room.
Right.
It can be a lack of pitch range when you suddenly just can't hit those high notes when you sing. It includes severe vocal fatigue, where speaking physically exhausts you by 2 in the afternoon. And it even includes the globus sensation.
Oh, the globus sensation. That is that feeling where you swallow and it feels like there's a permanent lump in your throat, right? Even when nothing is physically there.
Exactly. That sensation of a lump is actually categorized under this whole umbrella of dysphonia. So when a patient walks into a clinic with these issues, the first step in the algorithm isn't jumping to some invasive procedure.
Thankfully.
Right. It begins with a thorough history and a standardized self-assessment, like the Voice Handicap Index 10 or VHI-10. This tool measures how the patient perceives the severity of their own disorder.
See, I found that concept really interesting in the reading. Why is the patient's subjective perception so critical right at the beginning? I mean, doesn't the doctor just need to figure out if the vocal cords are broken or not?
Well, voice is fundamentally tied to identity and livelihood. Think about it. A slight rasp might be, say, 2 out of 10 for a computer programmer who rarely speaks during the workday.
Sure.
But that exact same rasp, biologically speaking, could be a 10 out of 10 career-ending disaster for a professional opera singer or a broadcaster or a teacher.
Oh, wow. Yeah, that puts it in perspective.
Quantifying that subjective impact immediately dictates how aggressive the treatment pathway needs to be.
That makes total sense. But moving past the questionnaire to the actual physical exam, I just have to ask.
Yeah.
We've all seen doctors say, and look in with a little light. Can a specialist just shine a light and look down there with a mirror to see what's wrong?
What's fascinating here is how limited that old school mirror exam actually is. Yeah, the larynx is deep, it is dark, and it is highly dynamic. To truly understand dysphonia, especially functional disorders, where the anatomy looks completely normal but behaves abnormally, clinicians absolutely rely on transnasal flexible laryngoscopy.
Right, which is threading a flexible camera up the nose and down the back of the throat.
It sounds incredibly uncomfortable, I know.
It does.
But it allows the clinician to view the larynx in its natural in vivo setting while the patient is speaking, swallowing, and breathing normally. If you use a mirror, you actually have to pull the patient's tongue out, which completely alters the pharyngeal anatomy.
Oh, I hadn't thought of that. You're distorting the very thing you're trying to measure.
Exactly. But the real technological lead in these diagnostic algorithms is laryngovideo
Okay, wait, because if the vocal folds are vibrating hundreds of times a second when we speak, wouldn't any camera just catch a giant unreadable blur? Like, how do they actually see the tissue moving?
You've hit on the exact physics problem. To the naked eye or a standard camera, it is just a blur. So stroboscopy uses a specialized strobe light synced to the exact fundamental frequency of the patient's voice.
Oh, clever.
Yeah, so if the vocal folds are vibrating at 200 hertz, the strobe flashes at just slightly off 200 hertz. It creates this brilliant optical illusion, basically piecing together a slow motion video of the vocal folds vibrating.
It's like watching a car tire on the highway that suddenly looks like it's spinning backward.
Right.
Because of the frame rate of a camera.
That is exactly it. It allows the doctor to see the mucosal wave. The surface of the vocal fold isn't just flapping open and closed like a door, it ripples. Seeing that microscopic wave activity and how the delicate layers of tissue under the surface are behaving during actual phonation is crucial. A simple mirror exam completely misses the most important biomechanical event in human speech.
Which brings us to the actual physical battlefield where this wave happens. When doctors zoom in with that strobe light, they're usually looking right at the membranous vocal folds.
Right, the anterior 2/3 of the vocal folds, stretching from the front commissure to the vocal process in the back.
The strike zone.
Yes, this specific area is the primary vibratory source for the voice. Because it does all the heavy lifting and absorbs the most mechanical stress, it takes the brunt of the impact. Repeated trauma, so shouting, chronic coughing, severe acid reflux, it creates a variety of physical lesions right in the middle of the strike zone.
And the sheer variety of ways we can damage this tissue is just wild. The clinical algorithms list 9 distinct benign mid-vocal fold lesions. We're talking nodules, polyps, subepithelial cysts. How do these actually differ functionally?
Well, think about the mechanism of injury. Vocal nodules are essentially calluses. They form bilaterally from chronic repeated friction over a long period of time, like a singer who constantly pushes their voice too hard.
Right.
A vocal polyp, on the other hand, is more like a fluid-filled blister that can pop up after a single massive traumatic event, like screaming at a football game. Yeah, but the structural difference that really dictates the surgical approach is between a vocal fold scar and a sulcus vocalis.
Right, because both of those involve detrimental cyclic wound healing. You injure the tissue, it heals poorly, you injure it again, but they ruin the vocal fold in totally different ways.
Exactly. A vocal fold scar replaces the delicate, pliable lamina propria layer with stiff fibrous scar tissue. It maintains the physical bulk of the vocal fold so the space doesn't shrink, but it completely ruins the vibration. Now, contrast that with sulcus vocalis.
Okay.
This is an acquired condition where a portion of that lamina propria is completely lost. It creates a groove or a divot, and the surface vocal epithelium ends up adhering directly to the deeper vocal ligament.
Okay, so if you imagine the vocal folds like a pair of guitar strings, the vocal fold scar is like wrapping a thick piece of duct tape around one of the strings.
Good analogy.
The string is still the same size, right? It takes up the same amount of space, but it vibrates poorly and sounds completely dead. But a sulcus vocalis is like taking a pocket knife and stripping the outer winding of the guitar string completely off, right down to the core wire. You're fundamentally reducing the bulk of the instrument itself.
That analogy perfectly illustrates the mechanical problem.
Yeah.
And that loss of bulk in a sulcus causes glottal insufficiency. Because the physical tissue is literally missing, the two vocal folds can no longer close it completely against each other when they try to meet in the midline.
So air just leaks out.
Exactly. Air constantly escapes through that tiny gap, creating a weak, breathy voice.
And it's not just the tissue layers either. The blood vessels themselves can cause chaos. The algorithms specifically highlight vascular anomalies. Normally, the blood vessels in your vocal folds run parallel, along the length of the fold, but sometimes they develop these anomalous lesions where the vessels run perpendicular like transverse across the fold. Why does the orientation of a microscopic blood vessel matter so much?
It is all about shearing forces. If a vessel runs parallel, it rides the mucosal wave smoothly during vibration. But if a vessel runs perpendicular to the vocal fold, it is sitting directly across the strike zone.
Oh no.
Yeah. Every single time the vocal folds clap together hundreds of times a second, remember they are physically shearing against that perpendicular vessel.
Wow.
Not only does it alter the vibration, but those perpendicular vessels are highly prone to bursting, which causes a sudden, massive vocal fold hemorrhage.
Just a devastating event for anyone who relies on their voice. But if we pull back from local trauma, the shouting, the coughing, the singing, the diagnostic tree takes a really fascinating turn here. Hoarseness isn't always a localized throat problem. Sometimes the larynx is a systemic warning light for the rest of the body.
This is a massive pivot point in the clinical evaluation. If an otolaryngologist looks down there and sees no obvious local trauma, no polyps, no calluses. They have to start thinking systemically. Neurological diseases frequently present here first. Parkinson's disease, amyotrophic lateral sclerosis, multiple sclerosis, myasthenia gravis. All of these can manifest initially as hoarseness or a loss of vocal control, long before major motor symptoms in the limbs become obvious.
It makes sense when you think about it. The larynx requires incredibly precise, rapid neurological control. Any subtle disruption in the central nervous system is going to show up in that delicate machinery first. But what about spasmodic dysphonia? The clinical guidelines spend a lot of time on this one.
Spasmodic dysphonia is a focal dystonia. It is a neurological condition where specific laryngeal muscles experience involuntary spasms, but only when triggered by phonation, so only when you try to speak.
Wow.
The abductor type causes the vocal folds to slam shut inappropriately, producing a severely strained, strangled-sounding voice. The abductor type causes them to pull apart randomly, resulting in sudden breathy dropouts in the voice.
And to fix this neurological misfiring, the primary treatment is injecting botulinum toxin Botox directly into the throat. That sounds terrifying.
It is a brilliant targeted application, though. By injecting a tiny, highly controlled amount of Botox directly into the specific spasming muscle, it interrupts the neuromuscular junction.
So it paralyzes it?
Temporarily, yes.
Yeah.
It temporarily paralyzes that single muscle, stopping the spasm and smoothing out the voice without ruining the patient's ability to swallow or breathe.
Okay, the neurological connection I can wrap my head around. The one that completely blindsided me in these algorithms was the rheumatological connection. The guidelines mandate looking for conditions like Wegener's granulomatosis, sarcoidosis, and rheumatoid arthritis. Rheumatoid arthritis in your throat.
I know, it is a detail that is so often overlooked. We naturally associate rheumatoid arthritis with the knuckles or the knees, but remember the laryngeal anatomy. The vocal folds are attached at the back to two small pyramid-shaped cartilages called the arytenoids.
Right.
Where those cartilages meet the cricoid cartilage below them, there is a true, fully functioning synovial joint, the cricoarytenoid joint.
So literally anywhere in the human body there's a synovial joint, systemic arthritis can strike.
Precisely. Systemic inflammation from rheumatoid arthritis can aggressively attack that joint in the throat, causing swelling, severe pain, and restricted movement of the vocal folds, which manifests as hoarseness.
That sounds incredibly painful.
It is, and this completely changes the treatment algorithm.
Yeah.
You don't just cut into arthritic larynx. The guidelines emphasize that surgical therapy here is an absolute last resort, considered only after the patient has received maximal medical treatment from a rheumatologist to quiet the underlying systemic inflammation.
So if cutting into an arthritic or deeply scarred larynx is off the table, how do you actually restore function to tissue that won't vibrate properly? I guess you have to fundamentally change the aerodynamics of how the patient speaks, which brings in the speech-language pathologist.
Exactly. Voice therapy is essentially highly specialized behavioral management. An SLP evaluating a dysphonic patient will perform stimulability testing.
Meaning they test whether the patient's nervous system and anatomy can actually be stimulated to change their vocal habits right there in the clinic.
Right. If the SLP gives them a prompt, a different mechanical way to breathe, a different muscular coordination to initiate a sound, can the patient physically execute it? If they can, they are a fantastic candidate for therapy. And what is crucial for patients to understand is the timeline.
It's not forever.
No, voice therapy is not an endless years-long psychological exploration. The algorithms note it typically involves just 6 to 8 focused sessions, rarely extending past 3 months.
So it's not taking a daily pill. It's like going to a physical therapist to completely relearn how to coordinate your own musculoskeletal system.
It is retraining the respiratory engine and the laryngeal machinery to work in perfect harmony. The algorithms even mention singing voice therapy, which uses vocal pedagogy techniques, and they clarify heavily that this is not just for professional singers.
Right, anyone can benefit.
The exact same biomechanical techniques used to rehabilitate a classical soprano are incredibly effective for a school teacher recovering from bilateral vocal nodules.
But if behavioral therapy hits a wall, and we are dealing with severe glottal insufficiency where the vocal folds physically cannot close the gap, the surgical interventions are pretty fascinating. Vocal fold augmentation is one of the primary tools here.
Yes, if a vocal fold is permanently paralyzed or severely atrophied, it leaves a static gap. Air just rushes through. Augmentation aims to physically bulk up that paralyzed fold to close the gap. One of the most reliable methods is injecting the patient's own autologous adipose tissue directly into the vocal fold.
You harvest their own fat and literally plump up the paralyzed vocal cord so the healthy one can actually reach it. And if injection isn't enough, there is medialization laryngoplasty, the thyroplasty.
This is pure biomechanical engineering. In a thyroplasty, the surgeon does not inject the vocal fold tissue itself. Instead, they cut a tiny window into the outer cartilage framework of the voice box.
Oh.
Yeah, they then place a physical implant, usually Gore-Tex or Silaptic, into the paraglottic space, which sits behind the paralyzed vocal fold. This wedge permanently pushes the paralyzed fold toward the midline, acting as a static backboard so the healthy moving vocal fold can strike against it and create a vibratory seal.
It is incredible what they can do. Now, up to this point, we've been deep in the larynx, dealing with the voice, communication, and quality of life. But half of our clinical sources are dedicated to a symptom that changes the stakes entirely. We move from dysphonia, the loss of the voice, to dyspnea, the loss of breath.
If we connect this to the bigger picture, dysphonia is a threat to your communication. Dyspnea is a direct threat to your life. Dyspnea is highly subjective. It is the patient's internal feeling of breathlessness, and it is monumentally complex because it represents the total overlap of the pulmonary system, the cardiac system, and the neurologic system.
It's all connected.
It is the body's ultimate non-specific alarm bell screaming that oxygen delivery is failing.
And the timeline contrast between these two symptoms is really jarring. With chronic hoarseness, you have time, you do a thorough history, you schedule a stroboscopy for next week, you try a month of voice therapy. But with severe acute dyspnea, you are instantly thrust into an emergency algorithm.
Exactly. The clinical algorithm for acute dyspnea abandons the nuanced history and starts with an immediate primary threat assessment. The physician is looking for cyanosis, tachypnea, tachycardia, and altered mental status.
Right.
These aren't just vital signs. They're indicators of impending cardiovascular collapse and severe brain hypoxia.
Because if the brain isn't getting oxygen, the patient becomes agitated or lethargic. The clinical pathways state that sometimes patients are in such severe respiratory failure that they must be intubated and placed on mechanical ventilation before any diagnostic workup can even begin. You secure the airway first, you ask questions later.
And the textbook gives a terrifyingly clear example of this kind of rapid-fire acute emergency in trauma patients. The tension pneumothorax.
Yeah, explain the physics of this because it's much more dangerous than just a simple collapse alarm, right?
Far more dangerous.
Yeah.
In a tension pneumothorax, a traumatic injury creates a one-way valve in the lung tissue. Air enters the pleural space, the cavity between the lung and the chest wall, every time the patient inhales, but it cannot escape when they exhale.
So it's just building up.
With every single breath, more air is trapped. The pressure builds exponentially, completely crushing the lung. But worse, that massive pressure causes a mediastinal shift, physically pushing the heart and major blood vessels to the opposite side of the chest.
Oh my God, moving the heart.
Yes, and that entirely clamps off venous blood return to the heart. It will kill the patient in minutes. You do not wait for an X-ray. The algorithm dictates immediate emergency decompression with a chest tube or a large bore needle to vent that trapped air.
It's just a pure plumbing emergency. But assuming we are in a trauma bay and a patient comes into a clinic complaining of chronic worsening shortness of breath, how do doctors isolate the cause? Because it feels like it could be 100 different things.
It could be, which is exactly why chronic dyspnea demands a multidisciplinary approach.
Right.
But for the pulmonologist, the detective work relies heavily on pulmonary function tests, or PFTs. These specific breathing tests divide massive, complex lung problems into two distinct mechanical categories: obstructive diseases and restrictive diseases.
Okay, let's break the math down on this a little bit. The two key metrics in these tests are FEV1, forced expiratory volume in 1 second, which is how much air you can blast out instantly, and FVC, forced vital capacity, the total amount of air you can forcefully exhale overall.
Right. Obstructive lung disease is fundamentally an airway resistance problem. The airways are narrowed or inflamed. In these patients, the ratio of FE1 to FVC drops below 70%, and in severe asthma, it can actually drop below 50%. Wow. This means their total lung capacity might actually be completely normal or even hyperinflated, but they cannot get the air out quickly because the microscopic tubes are blocked.
It's basically a plumbing problem again. If you've ever watched someone with severe asthma try to catch their breath, you are watching this obstructive math play out. It's like trying to exhale your entire lung capacity through a cocktail straw. You have a full lung of air, but the exit is so narrow that it takes forever to empty it. Conditions like chronic obstructive pulmonary disease, asthma, and cystic fibrosis all operate on this mechanical failure.
That is a perfect way to visualize it. Now contrast that with restrictive lung diseases. These are not an airway problem, they are an expansion problem. The airways are wide open, but the lungs themselves physically cannot inflate fully.
So the volume is lower.
In restrictive cases, the total lung capacity severely decreases. But because the airways aren't blocked, the FEV1 to FVC ratio is actually normal or even increased. They can blow out whatever air they have very quickly, they just have a tiny volume of air to begin with.
So a restrictive disease is like trying to inflate a balloon that is permanently trapped inside a tiny rigid box. The balloon rubber works fine, the opening is wide, but it just physically hits a wall and cannot expand.
Exactly. And that restriction can come from the lung tissue itself, fibrosing and scarring interstitial diseases like pneumoconiosis from inhaling industrial dust, or even severe scarring induced by medications like bleomycin for cancer or amiodarone for the heart.
Okay.
Alternatively, the restriction can be extrinsic, coming from outside the lungs. Thoracic wall issues like severe kyphoscoliosis physically cage the lungs, or massive obesity, where the sheer weight and abdominal pressure mechanically prevent the diaphragm from dropping and the lungs from expanding downward.
So we have all these incredibly complex, measurable physical causes, airway obstructions, lung tissue scarring, chest wall deformities. But what happens if you are a doctor? A patient comes in legitimately suffering from shortness of breath. But the PFTs are perfectly normal, the EKG is flawless, and the chest X-ray is totally clear. Can shortness of breath just be in someone's head?
The clinical algorithms do explicitly acknowledge psychogenic dyspnea, which is profound shortness of breath related to severe anxiety, panic attacks, or conversion disorders. But the guidelines strongly emphasize a cardinal rule of clinical medicine.
Which is?
Psychogenic dyspnea is strictly a diagnosis of exclusion.
Meaning a doctor cannot just jump to anxiety because the first round of tests came back negative.
Exactly.
Yeah.
It is incredibly dangerous to attribute dyspnea to anxiety without an exhaustive, relentless search. The feeling of breathlessness is so nonspecific that doctors must systematically rule out every single organic cause, from a hidden micropulmonary embolism to subtle cardiac arrhythmias or early-stage neuromuscular weakness, before they are permitted to conclude that the breathlessness is psychological. The clinical risk of missing a life-threatening organic cause and calling it a panic attack is simply too high.
It is a massive clinical responsibility. Bringing this all together, looking at the diagnostic trees for both dysphonia and dyspnea, they both ultimately represent massive disruptions in the flow of air through the human body.
They do.
It is just a question of what that specific air is supposed to be doing. With dysphonia, that air is being finely, microscopically manipulated, vibrating delicate tissues hundreds of times a second to create the very identity of our voice. With dyspnea, that air is being deeply, desperately inhaled to oxygenate our blood and keep our organs alive.
They really are two sides of the exact same respiratory coin. One defines how we connect with the world around us, and the other dictates how long we get to remain in it. And the clinical pathways we explored today show just how far modern medicine has to go to trace a seemingly simple symptom back to its hidden microscopic root cause.
It leaves you with something profound to mull over long after you finish listening. Consider how much of our human experience, our ability to share our deepest thoughts, to sing, to argue, and just our basic biological survival relies entirely on a microscopic, fragile balance of tissue tension, joint mechanics, and airflow. The next time you effortlessly speak a sentence or take a deep, satisfying breath, think about the incredibly complex, invisible symphony of anatomy that just performed flawlessly to make it happen.
A symphony we usually only notice when the music finally stops.
Beautifully said. That is all for today's deep dive. We'll see you next time.